There we go. Perfect. Okay, wonderful. Well, we will get going. Sorry for that delay. Uh, it's like every time you open Zoom, it has some sort of new update, and Macs and Zoom don't really get along. Just kind of give you guys a quick update. I obviously have not posted the recordings that I wanted to. I just personally have not had time to do that yet. I'm shooting for Monday. I know it's the last week, but you guys will at least have access to those video lectures, and we will be able to cover several topics in those recordings. And yeah, it's just what happened. I ended up on this really big forensic case, and it's just kind of eating my lunch. Like I said in my email, it is a kind of a once in a lifetime, once in a career opportunity, and I was really humbled to even be offered that opportunity. And so I've been trying to do an extra good job, and so far it's going well. It's just last week I wrote a 120-page opinion report that is just a preliminary report. And yeah, so that's kind of interfered with my ability to get some of that those videos posted, but I will get those and keep working on it, and hopefully have those up by tomorrow afternoon is my hope. So that said, I do want to cover yeah, Greg, is a lot. I do want to cover quite a few topics tonight, so hopefully we can get through most, if not all. If for some reason I'm unable to post those videos, I will 100% for sure offer an optional meeting one of the evenings this week. So probably either Wednesday or Thursday evening. Even though I think Thursday is officially the last day of school, but it doesn't matter. You're in grad school. We could do this on vacation. Just kidding. Not that you want to do that on vacation, but we will definitely cover quite a bit tonight. And then if you guys have any questions, it's just us three, please feel free to ask away, and hopefully can get you some answers. So before we get going, any questions or concerns or thoughts, hesitations, Thessalonians?
We don't have to talk about it right now. We can talk about it at the end. I'd love for you to just go over the delirium and then the brief psychotic episode differences a little bit more.
Yeah, absolutely. And that's something I can do real quick. So thanks for asking. And Greg, did you have anything?
None at this time.
Okay. Greg's at a basketball game, I think.
Basketball practice.
Basketball practice. All right.
Yeah, I'm prepping dinner, so that's why I'm like.
Gotcha. No worries. Greg, you won't believe me, but back in the day, I used to be able to dunk. I'm only 5'9", but
yeah, me too. I'm here with my daughter. She's starting AAU, so she's trying to get that underway.
That's awesome. That's cool. We had softball practice yesterday, and I pitched. I didn't beat anybody. All right, so let me share the wrong screen. Let me share the right one. And There we go. So Sarah, let me answer your question. We're kind of cover delirium. Is delirium versus dementia, is that right?
Delirium versus brief psychotic episode.
Oh, that's right. Okay. All right. So the biggest or the quickest way to summarize the difference between the two is that a brief psychotic episode is not going to be caused by a quote physiological or pathophysiological process, whereas a delirium will. In other words, a brief psychotic episode is typically stress induced. It is quite time limited, but it is tied to psychological factors as the sole etiology, as compared to a delirium, which can look exactly like a brief psychotic episode, except it is going to be a biological etiology or biological cause. And so I'm trying to think, I think I've seen a couple patients at some point with brief psychotic episode, but to be honest with you, it was one of those things that one patient that I recall clearly had quite a bit of trauma. And so it was a question of whether or not this was really better explained by like a trauma reaction. And then the other person had pretty substantial personality dysfunction, and which, you know, can make you kind of question not the validity of their perception, but certainly the utility of their symptoms. So in other words, their symptoms seemed a lot more instrumental in obtaining some sort of psychological need or relief, whereas the biological deliriums will be, in most cases, a lot more gradual in onset, unless we're talking about like an acute physical injury or illness. Particularly UTIs tend to be the number one cause across the board for acute delirium. From there, delirium states typically are caused by medications or I would say toxic effects of medications or substances. And then from there, you get a range of different types of deliriums that, for the most part, have onsets while hospitalized. So people who spend a lot of time in the ICU or were in a coma, people who, like geriatric populations, will often develop a delirium, even if they're in there for, like a knee surgery, simply from, and at least the theory is that the lack of exposure to sunlight and kind of the typical, I guess what they call the zeitgeist transition times of the day, where you have the mornings, the sun coming up and the sun going down. Without that typical rhythm, if you spend enough time inside, it will cause a delirium for everybody, but people who, like little kids and geriatric populations, are the most sensitive to that. So hopefully, does that help, Sarah? I'm gonna assume that was a yes.
Yes, sorry, I was trying to get back to.
No worries. Like to try to time it to see whenever you guys are furthest away from the mic. So what I'm going to do is I'm going to start with talking about dementia, and then I'm going to work ourselves back toward OCD, PTSD, and everything else. And so because dementia being an important piece of this class as compared to the pediatric psychopathology. And one thing to kind of keep in mind is when we talk about dementia, or when somebody says dementia, like, that person has dementia, what you need to understand is that's translated technically from the word dementia into the DSM-5-TR terminology, which is the neurocognitive disorders. And so you won't necessarily see the word dementia a lot in the DSM-5-TR. I'm not even sure if it's in there. But the neurocognitive disorders are the same thing. Now, here's the thing, is that when we say dementia, most of us, I would say, and if we're talking about it non-clinically anyway, what we mean is a form of cognitive decline that is associated with older age. And, there's the most commonly known one, that most people are aware of is Alzheimer's. But dementia as a umbrella term doesn't necessarily mean, and clinically doesn't necessarily mean, a progressive dementia or progressive cognitive decline. In other words, somebody could be, 40 years old, have a traumatic brain injury, and subsequently experience cognitive decline after that brain injury, and the brain injury itself reduces their cognitive ability, but in the absence of any further injuries, we don't expect that to keep going down. Now, later on, way down the road, that might play a role in the onset of dementia or the progressive forms of dementia. But in general, the term dementia just means that we've had cognitive decline, okay? Now, as it relates to the DSM-5-TR, you'll see that there are quite a few different types of neurocognitive disorders, some of which are progressive and some of which are not. Question is, well, how do you know which ones are progressive? Well, it really relates to the underlying pathophysiology of what has caused this. So, like I said, traumatic brain injury doesn't necessarily mean that we're going to continue declining after we are out of the accident. In other words, we will have a decline of cognitive ability, and depending on the severity of that TBI, we may or may not ever recover completely, but we aren't expected to continue on a path of decline unless there's some other disease process occurring that would cause that. So as that's compared to the most common types of dementia, or the most common neurocognitive disorders, as it were, number one being Alzheimer's. Now, Alzheimer's really has two different types of disease processes, where we've got the tauopathies and the neurofibrillary tangles. I can't ever say that very well, but essentially it's plaque and buildup of proteins that are misfolded that end up causing an inflammatory type of response in the brain, and subsequently killing off brain cells a little bit at a time. Now, there are two types of Alzheimer's. There is the early onset versus the late onset type. And the early onset, in general, is kind of considered before age 65. And really what I would say is the early onset is something that you'll see in, late 40s through early 50s, mid 50s. It tends to be closer to about mid 50s that people start to recognize like the early onset type. And in most cases, you can kind of see it coming genetically when you trace the family history back. So the early onset or the familial type tends to be associated with a higher genetic loading than the idiopathic type, which is the late onset type. And what the late onset type, what causes that one is mostly a combination of genetic risk plus lifelong chronic, I would say, just inflammation. That's the best way to describe it, because that includes poor diet, that includes physical illnesses and injuries or chronic illnesses, in addition to probably psychological trauma, things like that. All of those kind of just add, extra weights to the scale that if you get enough of those plus the genetic predisposition, it can tip the scale towards developing Alzheimer's. It's something like, gosh, I want to say something like 80% of people 90 and above will have Alzheimer's disease. But the truth is that if you're in your 80s and you haven't shown the signs of Alzheimer's, it's not super likely that you're going to end up having it. Now, it's not impossible. I mean, it still does happen, but people in their 80s without any signs of Alzheimer's typically don't go on to develop it unless we've got something else that happens that speeds up the process. But the reality probably is that if we could all live long enough, for the most part, most of us would develop the same pathophysiology or the disease process that causes Alzheimer's. So what is Alzheimer's? Alzheimer's is typically a dementia that some of the very first signs tend to be cognitive decline of memory, and particularly short-term memory, where we've got some of the daily routine stuff like how to drive to work, or how to drive home, or where the laundromat is, or how to brush your teeth, or especially names. That's another one. So the primary thing to remember about Alzheimer's is that it is primarily a cortical or an outside of the brain disease process, meaning that it affects the outside layer of the brain and not really as much on the inside of the brain. From a psychiatric standpoint, there's a lot of evidence pointing to the fact that Alzheimer's is likely to have the earliest onset symptoms to be depression. Depression, anxiety, and sleep disorders tend to be highly associated with it, which is not necessarily causative, but it's pretty clear that if somebody has like an onset for the first time ever in their life, like of depression, let's say in their 50s or 60s, and the type of depression that doesn't respond at all or very well to the typical therapies, whether that's medication or psychotherapy, then that's a pretty good case that this might be like a soft sign for an early or developing Alzheimer's. As the disease progresses, it tends to drastically disrupt the sleep-wake cycle. And subsequently, you can have like even a switching of the circadian rhythm to where people with Alzheimer's will sleep a lot during the day, take frequent naps, and then in the evening, they'll have what's called sundowning, as noted on this slide. Sundowning, by the way, also occurs with little kids. It's all little kids. Like I say little kids, but the younger they are, the more prominent the symptoms are. But sundowning is where when the sun goes down, there's like this revving up or an agitation that occurs. There's a it's almost like the brain's having a hard time transitioning from daytime to nighttime. The other thing with Alzheimer's that you will see towards the middle to late stage is some of the delusional aspects, even paranoia, including hallucinations at times, particularly at night. Again, it's whenever the sleep-wake cycle becomes disrupted. All right, I'm going to move us on. Talk about the second most common type of dementia, or progressive form of dementia. And looks like we've got a, Greg, I'm sorry to hear that. Yeah, and just, just to highlight, because I should have mentioned that a while ago, treatment for Alzheimer's, there are some medications that at least on average can slow it down. You can't stop it, but I do believe, based on the research I've seen more recently, that we are getting very close to identifying therapies that, or medications that can either stop it and or potentially reverse it. Now we've been very close for a decade, but I would say I would guess that within the next 5 to 10 years, they're gonna identify a way to stop it, if not reverse it. And I'm telling you, that would be a blessing and a miracle for many. So the second form, or the second most common form of dementia, is vascular dementia, and this is a subcortical dementia. So Alzheimer's is a cortical, and that's on the outside of the brain. Vascular dementia is a subcortical, or inside of the brain, disease process. And as the name implies, it's primarily associated with cerebrovascular disease. Just like you can have cardiovascular disease where you have high blood pressure, things, basically anytime somebody has high blood pressure in their body, just remember this, that's the same circulatory system that's going to the brain. And so we've got the biological disease process occurring in the body the same way as it does in the brain, causing a narrowing of the vascular lumen, or the hole, the actual size of the vessels from the disease process, and the plaque buildup from the cholesterol, stuff like that. Now, vascular dementia is probably also a cause of Alzheimer's pathology. And so there's a lot of overlap between Alzheimer's and vascular dementia, so much so that unless somebody has early onset Alzheimer's, in most cases, whenever I'm doing a dementia evaluation, I tend to lean more towards this being a mixed form of dementia, meaning that we're looking at probably a combination of Alzheimer's plus vascular. Now, vascular dementia also includes stroke. So if somebody has a stroke, and this is where it gets a little bit complicated, but vascular dementia by itself includes several different categories of dementias, one of which is like a slow, gradual decline as compared to an Alzheimer's that you're kind of going, and then there's just a pretty rapid drop. With vascular dementia, there's the typical process is a slow, gradual decline, because just like the body's wearing out, so are the blood vessels, and because they're wearing out, we've got a slower decline. You can also, though, have a stroke where you're cognitively normal, you have a stroke, you decline, and then you plateau right there because you're not having another stroke, and you don't have any other cerebrovascular disease going on. And so that type of vascular dementia is not progressive. It's not going to get worse unless we have another stroke or we develop cerebrovascular disease. Now, Other types of vascular dementia come from autoimmune conditions. There are several different things that can relate to that. And to be honest with you, COVID is probably going to be the #1 cause of vascular dementia for folks over the next few decades, would be my guess. Because we know for a fact that it does get into the brain. And just on a personal level, my mom has vascular dementia now as a result of COVID. And thankfully, it appears that the decline is a very slow process for her. But it absolutely had an onset and was identified after she had a pretty rough bout of COVID, and we actually even had an MRI of her brain about 6 months before she had COVID, and then 6 months after, and the comparison is just unreal in how different it is. Thank you, Sarah. I appreciate that. She's doing okay. In fact, she's doing a lot better than I could have hoped, and we're happy about that, and kind of taking it a day at a time. The biggest thing is everybody with dementia. What you need to remember: everybody with dementia, whether that's Alzheimer's or vascular or Lewy body or Parkinson's, will develop some sort of sleep disturbance. And so if you're working with somebody who is older and they have sleep, like chronic insomnia, and by the way, most people at that age with chronic insomnia are taking all kinds of sleep medication that's probably making it worse, if not causing it, meaning that there are some medications that are clearly identified now to be associated with causing Alzheimer's. Those are the benzodiazepines, by the way, things like Xanax, Valium, Ativan, what's the other one? Temazepam, Restoril. Greg asked, is that related to long COVID? It is, for sure. It's the same thing. So long COVID would be the cause of the vascular dementia for my mom, for example. Long COVID in younger folks can also cause a cognitive decline, but we are currently unsure if, it's expected that we can make a recovery from that. The guess there, based on other like viral types of cerebrovascular compromise, is that the younger you are, the less likely COVID is going to have any kind of long-term impact on your cognitive functioning. The older you are, the more likely it will. What does that mean? Like, is there an age cutoff that you're okay? We don't know. Plus, it's probably multifactorial with multiple variables associated with like making it worse or better prognosis. So, frontotemporal dementia is a close third with Lewy body dementia as the other form of progressive cognitive decline, and has the same pathology or pathophysiology as Alzheimer's disease, but instead of affecting the what's that called? It's the basal forebrain where the Alzheimer's pathology is. Frontotemporal dementia affects primarily the frontal and temporal lobes. You might have heard of things like Pick's disease or acquired sociopathy or primary progressive aphasia, semantic dementia, things like that. Those are all one and the same, classified under frontotemporal dementia. And here's the thing is that frontotemporal dementia goes underdiagnosed quite often, at least from what I've read and in my personal experience, because I'll get folks in, referred to me from neurology who've been, officially so-called diagnosed with Alzheimer's, in their early to mid 50s or so, who, with the testing that we do, or the evaluations that I perform, we can kind of determine where the pathophysiology is located better than like an MRI can. And in a lot of cases, what I've found is that these folks actually have had frontal temporal dementia for quite some time. Frontal temporal dementia is a lot slower of a decline than Alzheimer's, at least initially. In fact, there are case reports of it beginning in the 20s. And it's just a slow, gradual decline of the frontal and temporal lobes, and related to the same pathophysiology as Alzheimer's, but not nearly as efficient at actually like killing off neurons. And so it's characterized by decline of the functions of the frontal lobe and the temporal lobes, primarily the executive functions. Memory difficulties don't really show up until a little bit later, because it's not a true memory disorder as much as it is affecting one's ability to find the memories that are stored there. So executive functioning requires your ability to find the right file for long-term memory that you stored that memory in, and then bring it back for recall. But if you've got executive functioning deficits, you're going to have trouble finding that file because it never got organized correctly to begin with, even though the memory is there. And that's really the big difference. The other thing to remember about frontal temporal dementia is that you tend to have, if it's a right hemisphere type, it tends to cause like antisocial, like asocial kinds of personality change. And so you tend to see much more aggression, lack of empathy, things like that, or even just really odd and bizarre behaviors that are like, stealing stuff for the first time, or engaging in impulsive like sexual activities, stuff like that. I've been on several criminal cases where I've had to evaluate people for frontal temporal who ended up actually having it, who had committed like a sexual offense. And as it turns out, they had absolutely zero history of any of that. And then all of a sudden started having those impulses and compulsive behaviors that, in my opinion, are 100% related to the disease process, and weren't related at all to any underlying like personality dysfunction or mental health illness, or even something that they could control. That happens a lot, by the way. And I've yet to see a study on sex offenders, by the way, who have been thoroughly evaluated for frontal temporal dementia. I'm not trying to make light of what they're doing or the trauma and the psychological damage and harm that they do with the behaviors, but I just want to highlight that there are some of those folks that are at the mercy of their neurology, in the same way that any of us would be if we had the same disease process occurring to us. All right. Real quick with vascular dementia, the psychiatric stuff that you'll see with vascular dementia tends to be more depression, a slowing down of thinking, and sometimes even like a bipolarish kind of like profile. And so when you see those have an onset later in life for the first time ever, you can always remember that tends to be associated with vascular dementia. Frontal temporal dementia tends to come with like apathy, and not so much depression as it is just like either like anger, irritability, but not like sadness, and they'll even deny being sad, but just like anger, or just complete apathy, just flat, I don't care. And, there's just there's no concern for anything. All right. Lewy body dementia is really I would say, classified under a category or umbrella for Parkinson's disease. So Parkinson's disease by itself does not cause dementia all the time. Okay. Remember that. But there's a subset of the population in Parkinson's that will go on to develop a progressive decline of their cognitive ability. And that subset is called Parkinson's plus syndromes. So Parkinson's plus syndromes or Parkinson's plus dementia means that we've got a Parkinson's disease as the primary cause of what ends up being a progressive form of cognitive decline, and one of which is Lewy body dementia, or actually say one of which, the most common, is Lewy body dementia. It's suspected that Robin Williams had that, by the way. And as you can imagine, or associate, his depression was absolutely interrelated and closely tied to that disease process, which is probably what ended up causing him to commit suicide. Lewy body dementia is highlighted primarily, though, by a slowing down of thought processes. You have some memory difficulties, but those don't really come on until later. But what it looks like quite a bit is you'll have some cognitive stuff occur generally after the motor symptoms of Parkinson's emerge. I'm sorry, I said it the wrong way. You'll have the cognitive symptoms start first for a couple of years of cognitive decline, and then you'll start to see like a lateralized, like tremor, muscle rigidity, and even like some balance difficulties, things like that. The big thing diagnostically to remember with Lewy body dementia is that those folks tend to see very complex visual hallucinations. And it's not like they're scared of them. Like they'll be riding in a car with somebody else driving, and they'll look out into like a pasture or a field, and they'll see like a pasture full of like cows or animals. Or they'll see a deceased relative, but like completely see their full form, and it won't bother them at all. But so because of that, it's hard to spot a lot of times that they're actually having a visual hallucination, because it's not like real bizarre types of hallucinations. Just one second, I've got to turn my fan off because I'm getting cold. The other thing with Lewy body dementia to remember is that it comes with REM sleep behavior symptoms where the person will act out their dreams quite a bit at night. And so they are sleeping, but they will, it's almost like having night terrors, but like they'll night walk. I'm sorry, they'll sleepwalk. They will move around a lot in their sleep, things like that, and maybe even wake up in the middle of the night and be completely disoriented. Things like that can happen. Now, what I should say about all of this stuff, including every single diagnosis almost in that DSM-5, apart from just a few, sleep apnea in older age can mimic a whole lot of this stuff, especially the more severe forms. And so I've literally seen people in their 70s who, family they were getting ready to put them in a nursing home, who then had a sleep study. They identified, pretty severe and chronic sleep apnea. Subsequently had some treatment for it, like via CPAP. And then I saw them a few months later, and they were like spring chickens again and almost back to normal. So it's just a good rule of thumb to keep in the back of your mind always. And it doesn't matter if you're working with a 2-year-old or a 99-year-old. Sleep apnea and sleep disorders in general can mimic a whole lot of stuff, and they go underdiagnosed a lot because there's just not a lot of people out there that specialize in sleep. Okay. I'm going to jump back to some other topics. I'm going to talk about personality disorders, but before I do that, do you all have any questions for me related to dementia?
I don't have any questions.
Okay. Sarah, you got any questions? Okay.
I don't either, sorry.
All right. Sorry. I'm sure I keep timing it perfectly.
You're all good.
So I want to talk about personality disorders. Let me get that PowerPoint slide up here. All right. So here's the thing. I'm not a fan of the personality disorder diagnoses. Not because I don't think that they exist, but I'll say this is, it's and this is just my opinion, but it's my experience and my opinion that most people who meet the diagnostic criteria for a personality disorder have a history of chronic mental illness in some form or fashion, usually trauma, and or bipolar disorder, and or a neurodevelopmental disorder like ADHD. And the result of that chronic mental illness produces dysfunctional personality traits that can then be secondary classified into personality disorders. And so, in other words, I don't think it's possible to have a personality disorder without probably meeting the criteria or diagnostic criteria for some other mental illness that was probably a better explanation for what their symptoms are. And the reason why I even have beef with that is because personality disorders, one, there's not a lot of science, although there's a little bit, to back up evidence that there's a brain-related biological dysfunction occurring in the process of a personality disorder. Now, we do know that people with antisocial personality disorder or borderline and stuff like that have different or even dysfunctional connections between their orbital prefrontal area, which is right behind your eye, to the amygdala, which then translates into difficulty with regulating emotions, social stress tolerance, things like that, even attachment style. But again, that evidence doesn't go on to explore the possibility that another chronic mental illness can cause exactly the same thing. And specifically, I'll give an example. People with ADHD, especially untreated throughout their childhood and adolescence, tend to develop personality disorders at a much, much, much higher rate than the vast majority of the population. And it makes sense because ADHD is a frontal lobe syndrome, and the frontal lobe is where we get personality. On top of that, it also makes sense that if somebody has like ADHD or chronic depression or chronic untreated trauma throughout their life, they are experiencing a world or an environment that is directly shaping their frontal lobe, which is their personality, and conditioning their frontal lobe to have very specific and concrete, rigid traits and behaviors that are in response to whatever that mental illness was. In addition to that, the mental illnesses themselves, for example, depression, chronic depression, will lead to higher traits of antisocial personality and even narcissism, because it literally undermines one's ability to effectively engage in social interactions. So again, it's not that I don't think that they exist. It's just that I'm not a big fan of those diagnoses, because there's little data to support that they're really that discrete from other things chronically. And with oh, thanks, Sarah. With the personality disorders, I'll also say this is that there's not a lot of evidence to support treatment for it. And so apart from dialectic behavior therapy, Marsha Linehan, who's a psychologist with borderline personality, she has it herself. Apart from that form of treatment for very specific subsets of people with borderline, there's no other, it's not a lot of research data to support long-term efficacy for treating personality disorders, nor are there any FDA approved medications for it. And so when you don't see any medications approved for something, that's a good indication, by the way, that it's likely that that something doesn't really exist. Because I promise you, big pharma is good enough at business to find what works. And if they haven't found something that works and aren't making money off of it, there's probably a good chance that whatever it is doesn't exist. Okay? I know it's kind of cynical of me, but if you look at it that way, it really does help you kind of identify, like, a more objective view is that, you know, big pharma doesn't care if it exists or not, but they would have, if a medication was out there that would be effective at treating a personality disorder and not the secondary symptoms caused by some other mental illness, then you can bet your money that they would have profited off of that by now. All right. With all that said, though, we still need to yeah, so Greg, does that mean all personality disorders are comorbid? Technically, no. The DSM-5 won't go as far to say that, but anecdotally, and if you talk to anybody clinically, I can tell you, I have personally never met somebody with any personality disorder that didn't have something else. Like I said, either PTSD, chronic PTSD, depression, chronic depression, or bipolar, or something like ADHD. And a lot of times it's all of the above. Yeah. Now, there is research to support that some of these traits start to emerge in childhood, which might predate the onset of the mental illness. But the problem, though, is that even if that's true, that doesn't mean that we've got a separate thing. All it means is that we might have a predisposition for some of these traits, and that the onset of whatever else it is, you know, whatever mental illness comes, might be what ultimately shapes that person down that path. But because we know the frontal lobe doesn't stop developing until we're 25, and this is my rule, and I get kind of perturbed whenever I see it clinically out there, but I don't feel confident making a personality disorder diagnoses before the age of 20 in most cases. But I've seen psychiatrists and psychologists and professional counselors make it all the way down to age 4 and 5. And that's a lifelong disorder. And all that tells me is that whoever made that diagnosis does not know anything about the brain or the brain development. because there's a lot of dynamicity left, even in teens, so much so that I'm telling you, I've seen an 18-year-old who I was like, this person is antisocial, borderline, and narcissistic all bundled together, who then I evaluated about 4 or 5 years later, who did not have those traits anymore. I've personally seen that. Now that's a N, N equals 1, but I also suspect that that's not all that uncommon. Because if you'd have met me as a teen, I'm a lot different person now than I was before my frontal lobe was developed. Let's just say that. So, okay. Some of the big personality disorders. I'm gonna have to wrap this up here pretty quickly. I know I didn't get to trauma, but like I said, I am gonna either post some videos or offer another class. But let's talk about real quick some of the characteristics of the personality disorders that we'll come across. Really, the most common, and just my experience and from what I've heard from other folks clinically, is narcissistic personality disorder. And it's a spectrum to where if you don't have any narcissism or any of these traits, then you're probably going to be unlikely to achieve much in life or think highly enough of yourself, or value yourself enough to pursue anything either pleasurable or worthy of your time. On the other side of that, there's some sort of cutoff, and it's arbitrary cutoff for DSM-5, but there's a cutoff to where those traits begin to interfere with your ability to sustain, or I would say develop or sustain relationships, sustain employment, or complete daily functioning tasks. And at that point, in my opinion, that's where it becomes diagnosable. So when you read about all the personality disorders, I want you to think about, we are all on the spectrum of all of those. There comes a point at which the rigidity of those traits, meaning that those traits are present across multiple contexts, and to the severity that they interfere with our functional abilities in relationships. When that starts happening, that's when we need to start considering a diagnosis. Okay, that's really the best way to think about all the personality disorders, is that until they affect relationships or our daily functioning, we can say that person has more of those traits, but we certainly want to be cautious when we are throwing out labels such as these the personality disorders without considering that they are a lifelong diagnosis. That label is going to be with that person for forever. So you're saying that this person's forever going to be a narcissist if you diagnose narcissistic personality disorder, and that there's no hope that they'll ever get better. And two is that you're also saying that this person has such a severity of symptoms that you can correctly judge and accurately judge its effects, to the extent that beyond just, or I would say in any kind of objective or meaningful way. And so I'm not saying I've never made these diagnoses. I do, and I have. The longer I've practiced, the more hesitant I've become in making these diagnoses, because I've got several reasons, as you've heard now, but also because the stigma associated with it is often, I would say, gosh, what I'm trying to say, it's a self-fulfilling prophecy, I guess is what I'm trying to say. So like when you label somebody with that, your own bias and perception begins to see that person as that only. And I would caution you as a therapist, because if you think somebody has a personality disorder and you get kind of that confirmation in your mind, that's going to bias your perception of everything they do, whether or not whatever they're doing is related to what you think is that personality dysfunction. So, okay. I know I didn't cover the rest of those, but that's a good summary, really, to be honest with you, of what I think is the most clinically relevant related to this stuff. Now, I will either do a video or post or have another offering for a class. And if I do that, I will also record that and post it so everybody can see it. In the meantime, I do need to wrap up and head over to my next class. But what questions do you guys have about any of the stuff that I covered tonight?
So, Dr. Armstrong, as far as the final goes,
Mm-hmm.
the final, if I'm correct, it covers 6 through 10 or 6 through.
Yep. Covers
Okay.
week 6 through 10. Yep.
Oh, okay. Okay.
Yep.
Gotcha.
And you definitely want to make sure to get that done by
Tuesday.
right. Right.
Okay.
Let me see. I was in the wrong section. Yep. So you've got until, let's see. Yep. The 23rd, which is actually Thursday, 12 p.m. But don't wait till that long because I've got to do all the grades that afternoon.
Okay.
Yep.
I won't wait till that last minute.
Man, every semester, and I've sent out reminders and stuff and just like pleading, like begging people, please take this exam. And then like on Friday, usually it's like Friday night, it's like, I thought the exam closed tonight. I haven't read any emails that you sent ever. Yeah, please don't do that.
Oh.
Okay. Yeah.
I'm not worried about y'all. Y'all showed up. Like y'all aren't who I'm talking to. Yeah.
Greg, I did it yesterday. It wasn't too bad.
No,
There were a
Okay.
couple of questions, but some of them process of elimination.
Yeah,
Okay. Yeah. Yeah.
there's a couple questions on there that I might end up discarding, and just because they're not great questions. But yeah,
Do you have another class, Dr. Armstrong?
I do. Yep.
Okay.
Yep. Did you have a question?
I did. It was about a question on the midterm
Yeah.
that has to do with the delirium and brief psychotic episode.
Okay. Let's talk about it.
Yeah, it is question number 6 from the midterm, and it was, what is the main difference between a brief psychotic episode and delirium? And my first guess was wrong, but my second guess I have as delirium is time limited and context based, but I'm just really unsure of kind of why that is. Like, I have a good grade, but I kind of want to go back and just try to answer things correctly just because I'm a perfectionist. But the options are brief psychotic episodes are very brief, or sorry, psychotic episodes are very
Right.
brief. Delirium has an onset prior to psychotic episodes. There is no difference between psychotic episodes and delirium, which I believe would be wrong. And delirium is a time limited and context based.
So if I were taking this, I would probably select delirium as time limited and context based. Let's see if that is.
That's what I put.
Let's see if that's marked correctly there. Let's see if I get it right, guys. I mean, I wrote the thing.
Yep, that's it. That's what I put, and I got it right.
Mhm. So, I should have probably put brief psychotic episode there to make it a little bit easier of a question, because psychotic episode's kind of more general, right? But the big thing is, like, a psychotic episode is gonna be for the most part, like, when we say that, when somebody says somebody had a psychotic episode, it has a psychological, like, cause, and typically is associated with a pattern of psychotic episodes,
Okay.
as compared to delirium, which is really more of a cognitive disorder. Like, it's like a developing Alzheimer's for a short period of time.
Mhm.
Or another way of saying it too is, if you ever had your wisdom teeth, or had anesthesia, and you come out and you're just like not all there, that's delirium.
Mhm.
Yep. At least I hope it is, because I said some mean stuff to that dentist whenever I was in my 20s. I had mine taken out. I'm going to use that as an excuse. Yeah.
Thank you.
Yeah. So hopefully, does that help?
Yeah, it does a lot. Thank you.
Good. I mean, I hope so, because I gave you the right answer on it. That's the benefit.
Just the explanation was helpful.
Sure. Well, and that's the benefit coming to class. All right. Well, thank you, folks. I'm gonna pop over to my other class, but we will be in touch through email. So stay posted. See if there's any videos I can get posted, and or invitations to another optional class. Okay.
Sounds good. Thank you, Dr. Armstrong.
All
Yes.
right. Thank you, doctor.
Absolutely. Y'all have a great evening.
All right. You as well.